What's up, everyone? Dr. Jeff Lewis, former Major League Baseball physical therapist. So for those of you that have followed us for a while, you know that my background and specialty is primarily in treating baseball players. That's what I predominantly see in our clinic. That's what a lot of our content is on. But the other side of our practice that I see is active adults that are really, trying to maintain an active lifestyle while dealing with an injury. Specifically, those that are dealing with shoulder pain. So I want to talk today a little bit more about that, and specifically these individuals that are dealing with rotator cuff type symptoms, and really how it impacts not only their day-to-day, but really just their ability to kind of work out in general more than anything. So when we look at this kind of population, it's historically kind of 40 to 50-year-old individuals, very active background, or still presently very active, dealing with some type of gradual onset of shoulder pain. Really, pain with sleeping especially is the big one. So they can't sleep on that side. If they do, they get this pain down the side of the arm, nothing past the elbow, but really down the side of the arm. If it's going down to the kind of hand and finger, then we are being a little more, we're trying to be a little more cognizant of, okay, is this a cervical radiculopathy or nerve root issue? But this historically for rotator cuff is kind of down the side here more than anything. Pain with this kind of, we call it painful arc. So if they do have kind of full motion or relatively full, this middle range here is what's going to be very bothersome for them. In severe cases, when they're bringing their arm down, if their arm just kind of drops down like that, that's very classic kind of rotator cuff, a little more significant rotator cuff injury. Some other kind of things are, reaching out to the side is bothersome for them. Reaching when they're in their car and they go to change like the volume or their stereo or something like that, reaching forward, that's bothersome for them. These are all things that I kind of, when I hear this, I'm thinking, okay, this is probably some type of rotator cuff pathology. And for the context of this video, I'm going to talk about these injuries that we manage conservatively, so non-surgically, but a lot of this can definitely be applied in the surgical sense. And I think it's important we talk about that because a lot of people think if they have any type of rotator cuff symptoms, they need surgery right away. Anyone that's had rotator cuff surgery will tell you it sucks. Now, there are people that absolutely need it. People that have failed like at least 3 to 6 months of conservative rehab. Typically people that have a lot more high energy, high force traumatic injuries. So like a car accident, a fall, anything like that, where there's a big injury to the shoulder and they really they can't lift past here. Those are potentially going to be a little more surgically indicated than others. Not always, but definitely a much more of a consideration. So what I want to talk about first is really the anatomy of the rotator cuff. So you have 4 rotator cuff muscles. You have on the back, just the back of the shoulder. You have your infraspinatus, which is comes right from the back of the shoulder blade, and your teres minor. These are your 2 primary external rotators of your rotator cuff. So when you're doing exercise down the side here like this, those are the muscles you're working. Then you have your supraspinatus. So its primary job there is maintaining humeral depression in these initial phases of abduction. Really these kind of initial phases like right here. And it comes from the top, right above this kind of scapular spine, and it comes underneath almost through that subacromial space, and with the infraspinatus and teres minor attaches to the front of the shoulder right here, okay? Then we go to the front of the shoulder here, and we have our 4th rotator cuff muscle, which is called our subscap or subscapularis. It's the primary and only internal rotator of the 4 rotator cuff muscles, okay? So that is we're going to come back to that because that's important, to just that muscle in particular in this case. So that's the role there, or the anatomy of the rotator cuff. Now, I want to talk about traditional rotator cuff rehab in these cases because specifically and historically, the 2 muscles that are injured in these cases are typically your supraspinatus and or your infraspinatus. It depends on how each person presents, but you need to make sure you can tease out whether one or both of them are involved or some type of involvement rather. So that's that. Now, with traditional rotator cuff rehab, a lot of times people go into a clinic, they say, they get evaluated, and they're told you have a rotator cuff injury or whatever it is, start doing a ton of external down here. I'll be honest, I used to do that. I have since moved away from doing that for just about everyone that fits into that mold. I have found for most people that movement is much more provocative and also potentially make them worse more than, especially if the infraspinatus is involved. I have found in these individuals, when you do a lot of external rotation to the side here, they generally do not have great stability in that shoulder. And it's going to cause a little bit of a further kind of destabilizing effect on that shoulder and cause some more symptoms around the front of the shoulder, whether it's on the footprint or where those 3 rotator cuff muscles attach, or on the bicep tendon, which can be another big source of pain in these cases, okay? So that's the one thing to be mindful of there. The second thing is the role of the shoulder blade. A lot of times in these cases, everyone just does a lot of exercise where it's down and back, which is not wrong. I do that. However, we have to be mindful of the shoulder blade's ability to perform upward rotation and to posteriorly tilt. So when you're moving your arm up overhead, if you do not have those 2 motions of the shoulder blade, what's going to happen is you're going to try to compensate by getting more movement through the shoulder, which is going to lead to greater superior humeral migration and compression on that supraspinatus, or further anterior humeral migration like this, which further overloads that kind of anterior footprint of the cuff muscles or the bicep tendon. So you have to be able to address those two scapular components, specifically by strengthening the lower trapezius and the serratus anterior. The third thing I want to talk about here is the role of the subscap. Again, we talked about the subscap being a prime internal rotator. The other big benefit and role of the subscap is it can serve as one of the primary resistors to anterior humeral translation based on where it's positioned and attached. So when that humeral head gets kind of loaded forward, the role of the subscap is to help kind of center that posteriorly back into the joint. So that's why we do a lot of subscap movement in these cases. Now, the last thing we want to talk about is how we go about integrating the arm and the shoulder back into some more gym-based lifting type movements. Historically, in these cases, for these individuals, they're going to feel a lot better with rowing, pulling motions earlier than they will with pressing. The reason being, historically, kind of going what we talked about, how already a lot of these individuals, they have that humeral head that's already naturally positioned forward and pre-tension in the front of the shoulder. With pressing movements, they tend to just end up, when they go to press, they end up just further loading onto the front there. So we typically start with more rowing-based movements, so the arm kind of the humerus coming back towards the trunk in either a horizontal or a vertical position, pulling down like that. So we will start with rowing in both of those positions from a horizontal and a vertical pulling standpoint. In these cases, too, we will also try to do some closed chain work. So closed chain meaning your hand is fixed on the ground, so like a plank position or a bear crawl, something like that. That is a closed chain drill. An open chain drill is when your hand is not fixed, when I raise up overhead like so. So with closed chain, the reason we like doing that is because it challenges the true ability of the rotator cuff to center that humeral head within that joint. So when we're in a plank, the ground reaction force is going straight through our limb, and it literally wants to push our shoulder straight back out and straight up. So the job of the humerus is to keep it both centered in the joint and to keep it depressed as well. So you're not getting a lot of this humeral migration superiorly nor anteriorly. So that's the job of closed chain drills. So we will start and maybe just some like tabletop weight shifts, then tabletop shoulder taps, get to a plank position. The benefit of this more than anything with closed chain, this is why I do it so much with baseball players, but especially in this population of active adults with shoulder pain and rotator cuff issues, is you get co-contraction of the rotator cuff and the scapular musculature. So what I mean by that is your shoulder blade muscles and your rotator cuff muscles have to work together to stabilize and allow for movement at that joint, which is exactly what we want when we're doing these overhead types of movements, just in a different pattern more than anything. So that's kind of the other big things there. So we start with rowing movements, horizontal into vertical, to get, again, getting good scap recruitment, making sure when you're rowing, you're not going way far behind your back like so, where you're rowing back, you're rowing past midline, and now that humerus is getting kind of pushed forward again like that. And then the other side of that is the closed chain drills more than anything. So you can start a lot of times just in these kind of 90 or below closed chain drills. We eventually move to overhead, but we want to really max out in this kind of 90-degree, like traditional high plank position, things like that to get good serratus and rotator cuff work. The last thing we then work to add in there more than anything is the pressing movement. This is the last thing because it is typically the most provocative for a lot of people, and I purposely slow play it more than anything. I just have found if you try to rush pressing a lot of times in these cases, it just doesn't go well. You need to really make sure you have a very strong foundation laid in all the areas we've talked about before we say, hey, let's start pressing here. But when we already start pressing, again, we are going to start horizontal. So like, pressing in this movement before we get into pure overhead pressing. So from a horizontal standpoint, we might start with some block push-ups. You're in a traditional high plank position, but you have a block, so you're preventing you kind of from dipping into this forward position here. So we'll do that. We'll maybe do a floor press. So you're lying on your back, you're coming down with the weight, and the floor is literally stopping your arms from going back any further like that, and then you're pressing up. And then we kind of get into our just general from there, dumbbell bench, and then lastly, barbell bench. I do barbell bench last because it locks you into this very internally rotated position here, has a greater tendency, just from personal experience, if you're not prepared for it, to get that shoulder pushed forward, and historically just doesn't feel great in these individuals. And then from a pressing standpoint, overhead, I like to always start with the landmine press. If you don't know what a landmine press is, you can do a quick Google search, you'll see it. I probably have it on my YouTube channel here as well. There's a lot of different variations. I really enjoy it because it allows for modified overhead movement at about 120 to 140 degrees of shoulder flexion. You get great scapular upward rotation and recruitment. You get a thoracic spine component, and it's just not pure overhead flexion. So it allows you to get a good overhead stimulus in a controlled way and gradually build up from there. And then next, we'll maybe move into like a kettlebell overhead press or dumbbell overhead press. And the last thing we'll do is a strict military press overhead. That's really kind of what that pressing variation looks like. One thing I didn't talk about is the role of pull-ups. Historically, in these individuals, pull-ups are really problematic, especially when they get down to the bottom here and like hang into that position there. Where when you're hanging without any engagement, you're essentially just jamming up that supraspinatus into that subacromial space along with the bursa and the long head of the bicep as well. So I never have these individuals dead hang. That's probably a topic for another video and conversation because I have some strong opinions on that, but I never have them dead hang. Pull-ups is going to be a big piece of it though, where we maybe start with just an engaged hang and then you go into some kind of knee raises, leg raises, and then before you kind of get into a pull-up. So those are really the kind of tips for success that I would say if you're, again, that active middle-aged adult, 30, 40, 50-year-old that's dealing with these kind of those symptoms I talked about at the beginning, probably in line with some type of rotator cuff pathology. Obviously, if you're not sure, you have to get evaluated, and you'll get evaluated first more than anything. But those are some of the common symptoms I listen for when individuals like that come into our clinic, and really just kind of take those keys that I have, keys for success and advice I mentioned in this video, take them into your rehab. Talk to your clinician about it. Talk to whoever is helping you kind of guide you through your rehab and see if that's appropriate for you more than anything. But if you have questions on your rotator cuff injury or just shoulder pain in general, how to get back to lifting, drop the questions below in the comment section and subscribe to our channel for more content like this.